Ladies and gentlemen, good afternoon and welcome back. You know why you're here. Your boss for the past 7 years announced a few weeks ago that he was going to retire. So for his first speech since making that announcement and for his last speech to this conference, please welcome Sir David Nicholson.
Okay, well, good afternoon, everybody. Yes, this is not a pre-retirement do, by the way. This is a real thing, and I've been told that I've got to keep my chimp in the back, whatever that means. But you'll be able to judge how successful I am as we go through all of this. Well, it's great to be here. Great to see you all. Great to meet people around the Confederation conference. I've been reflecting, of course, as I normally do when I make this kind of speech about the past year, and heavens above, what a year it's been, hasn't it? In all sorts of ways, both for the NHS and I guess for me personally. But I'll come on to that in a while. I feel I've got a lot to say. I've got a lot of things I want to do over the next period. So I'm certainly not in pre-retirement mode. I'm going to talk to you this afternoon about some of the things I think we all need to do over the next period, important things, I think, that we can get on with and that I can get on with in my organisation. But just to say a little bit, first of all, about the decision I took to retire. And indeed, it was the timing of that, and there has been some speculation, I know that, but the timing of it was absolutely driven by this conference. One of the things for me about the NHS Confederation, which I think is a fantastic body and does absolutely remarkable work with and for the NHS, is it's my opportunity in the year when the NHS comes together, all the various bits of it come together in one place. And I can talk to the NHS about how we've done so far and what we're doing in the future. And it seems to me this is such a crucial time for the NHS. And it was, for me, such a crucial opportunity to speak to you. I genuinely thought that if I had any doubt in my mind that I was going to see some of this through, I couldn't give you an authentic speech. I would be, if I talked about the great things I was going to do for the next 5 or 7 years or whatever it was, it just wouldn't be authentic. So I decided that I'd make the announcement before this conference so I could be really clear with you about my reflections on where we are and what we need to do going forward. And there were 3 reasons that I decided that the time to retire was right. The first one, by March 2014, I will have done the job of Chief Executive of the NHS and Chief Executive NHS England for almost 8 years, which I think is quite a long time to do a job like this. They get rid of American presidents after that. So Chief Executive of the NHS, it seems to me it might be time to move aside. So we've all got tough jobs. You've all got tough jobs. I understand all of this. But this is a very sort of intense job to do. And there's a limited amount of time that you can be absolutely at the top of your game to do it. And making the right decision about when it's right, both for you and the NHS to go, is a really important decision to make. The second one was about, I have to say, I've really enjoyed the last 18 months, 2 years or so, in the sense that I really do believe that we were given a huge mountain to climb, and I wanted to work with you to get over that mountain. And we've made remarkable progress, and I'll talk a bit about that in a while. But what that's done, particularly in the environment, I've been able to work with my colleagues, with Malcolm Grant, who some of you will have heard yesterday, in NHS England, to start to build a new organisation and a new system to make change happen in the NHS. And I'm genuinely excited about that agenda, the kinds of things that we need to do in the future to make great services for our patients and our communities. But it's going to be a medium to long-term job. I think I would have had to have committed another to 5, perhaps 7 years in the job. And genuinely, I thought at this particular time you needed someone who was going to go and see that through. And I certainly don't see myself as a kind of Margaret Thatcher figure going on and on in relation to all of that. So that was the second reason. And the third was really reflecting on the last few months. One of the things I think about being any kind of leader in the public service, and in particular I think in the NHS, and you know this in lots of ways better than I do, the amount of scrutiny that you're under is absolutely extraordinary. And I've been under, enormous scrutiny, as you know, for those of you who read the Daily Mail. There's too many laughs there. There are too many of you read the Daily Mail. And to be honest, I became the story. One of the things that Tim Kelsey works with me at NHS England said before the Francis report was published is, I can't work out what the story is. He said, because all of this is in the public domain. Everyone knows what happened there. What is the story? He said the day after, I've realised the story's you, which was not what I meant it to be at all. And being that story, I think, makes it more difficult for me to do my job. It makes it more difficult, I think, to make the changes that need to be made. So on that basis, I decided those three things coming together made me make the decision that I did. And it was great, with great sadness. I've worked 35 years in the NHS. I'm deeply committed to what it does. I feel it very strongly. I want to continue to be a staunch proponent of the NHS, and to speak out on things about the NHS and make a difference if I possibly can. But for the meantime, I'm going to focus on the next few months, the next 10 months that I've got to do a whole series of things that I really, really do want to do. Now, I talked a bit about the level of scrutiny that we're all under and the pressures that we are all under in the NHS at the moment, and you see it every day in the jobs that you do. Heavens above, the job is difficult enough without some of the extra things we have to deal with, some of the absolutely overwhelming scrutiny that's put on what we do, everything from the kinds of tea bags that we use to the hotels that we stay in is absolutely part of the public domain at the moment, and is well publicised in the media, and that makes the job more difficult. Indeed, certainly over the last few months, I've felt that there's somewhere out there's a sort of wheel that gets spun every so often. And on that wheel, this week, it's nurses. Let's criticise nurses. Let's have a go at the nursing profession. Let's all attack what nurses do. Or it's spun another week and it's general practitioners. Let's have a go at general practitioners. I should say that every week it's spun for managers, but that's another story altogether. But I was particularly, I think, incensed about some of the coverage in relation to general practice. One of the things that I can do as part of my job is I get out around the service quite a lot. I meet lots of people. I see lots of great services. I also meet my counterparts from different countries, and universally, the potential power and contribution that general practice makes to the health and well-being and healthcare and the running of the NHS is absolutely enormous. Absolutely, it is in lots of ways the distinguishing characteristic, the distinctive characteristic of the NHS. Whether I'm talking to my colleagues in China or the Middle East or developing countries, they're all interested in primary care. They all want to bring that kind of approach, general practice, into their own organisations. The way in which we deliver general practice in this country, which is by no means perfect, is looked around the world as being something really significant. And not only does that make a big difference to our patients and our communities, over the last 18 months, literally hundreds of general practitioners have put their head above the parapet. In lots of ways, you could imagine, can't you? The money's run out, there's no more growth in the system, and we're having one of the biggest reorganisations ever in the history of the of the NHS, the pressure is on, and yet hundreds of general practitioners said that we will take a leadership position in the NHS. We're prepared to make that commitment to taking the NHS through some of its most difficult days. And all credit, it seems to me, to those people who did that. They've done a fantastic job taking it forward, and I think we're only at the beginning of understanding what the contribution that general practice can make about for the NHS going forward. Now, what I want to talk about particularly is the future. But if I just talk very briefly about the last 12 to 18 months and the changes that we've all seen and been through and gone through. This is the 4th year in succession that the NHS has had little or no growth. Never in its history has it managed both to improve services for our patients and to continue to be strong financially over a period as extended as that. That is a remarkable achievement by the people sat in this room. Never before has it been done in the NHS's history. Absolutely remarkable. At the same time, we've completely changed the superstructure of the NHS in terms of commissioning. We've completely changed all that. In that period, we've lost over 20,000 people. People who have, for a whole variety of reasons, have given most, if not all, of their working lives to improve the NHS and to work within it. And we should genuinely recognise the contribution that that people have made who have left us over the period. Which leaves us with the people in this room. And if you think about it, and the Secretary of State talked about it, I think very eloquently this morning, about what we've actually delivered over the last period. We've continued to work to improve services for patients. Most of the measures that you want to use about the NHS, we've delivered, we've done what we said we would do. And that's an important thing that you should be absolutely proud of and create the optimism that we need for the future as part of that. So genuinely thank you for everything you've done and continue to do to make the NHS what it is today. But I really want to talk about the future. I want to talk about the future in terms of what I want to do over the next 10 months or so, and what I want to work with you to do as well. There is, as we know, an enormous amount to do. And what I want to talk to you about how we can take the steps needed to promote a positive culture in the NHS. I want to talk to you about the steps that we need to take to plan for the future, to make sure that we are not victims of the political debate or the media storms that come and go with us. How can we take control of the future? And thirdly, I want to talk about the role that our patients will play in all of that. Now, there's a lot of stuff talked about culture, as you know. And one of the things about culture, if you want to change culture, and it is complex, it is not straightforward or easy at all. Those people who think you can switch a button or you can just announce a change in culture or whatever, they're completely wrong. And indeed, in the NHS, there are lots and lots of competing cultures. There is not one dominant culture in that sense. But there's lots talked about it. And the climate that you do it is really important. And I think we're operating in a really extraordinary climate. If you think about it, and I think Mike Farah mentioned this on yesterday when he talked. This time last year, we were just building up to the Olympics. And there's lots of scepticism, as I remember, about the Olympics and what happened, but they were absolutely phenomenal. And one of the things about the Olympics was the opening ceremony and the way in which the NHS played its role in there. And I don't know what it felt like where you were or what it felt like with the people that you worked with. I was in London for the whole week, the whole period, because they brought all the health ministers from all over the world together. But I don't know what it felt like where you was, but I felt enormously about. There was a swell of kind of feeling about the NHS. I saw it particularly amongst the ministers from the other countries who were absolutely overwhelmed by the idea that a country would have in its opening ceremony a celebration of its healthcare system. They just couldn't imagine that in their own countries that would be the case. And they were genuinely and absolutely interested in the way we delivered healthcare and the things that we did. And I spent lots of time, both then and subsequently, talking to international people about the NHS and the contribution that it makes. We all felt good about it. I felt good, and lots of people felt fantastically good about it. And yet, if you read the newspapers today, only sort of 10 months later or whatever, you'd think we'd have the worst healthcare system in the world. And that's a real problem to try and promote a positive culture in. That pendulum, the way it swings backwards and forwards, is very difficult for us to deal with. And in fact, in lots of ways, over the last few months, we've got ourselves into an even more difficult position in relation to it. It's interesting, at the moment, today, as we sit here, we have the lowest hospital mortality rates since the records began. Every year, over the last few years, hospital mortality has fallen. It's gone down by about a half in the last 8 or 9 years. On the other side, really bad things happen to some of our patients. Sometimes we fail them and their families significantly. Now, both of those things are true. The danger at the moment, if you talk about bad things that happens to our patients, lots of people say, it's not true, what about the great things in the NHS? And if you talk about hospital mortality going down, it's almost as if you deny that there are problems in the NHS. The reality is, both of them are true. Both of them are true. And we need to recognise and understand that both of them are true in order to make the right decisions and to develop the right culture and the right response. I started my NHS career as a junior administrator in the mid-70s in a hospital, a psychiatric hospital in the north of England. It was a 1,500-bedded psychiatric hospital. Remarkable organisations for those of you who would have been engaged and involved in them. It was, in lots of ways, extraordinary. It was one of those places where there was a group, actually there were two groups, amongst the nursing staff who absolutely ran the place. The nurses were the power in the land, and in particular, the cohort of charge nurses. In those large psychiatric hospitals, those of you who worked in them will know exactly what I mean. And as a junior administrator, getting into that group, getting involved in that was a really important thing. That was the way that people like me saw that we could make a difference to patients. We could make things happen and improve services for them. And I was no different. I wanted to do that. And I got an invite one day to the charge nurses' breakfast. This was a big deal. I was young and inexperienced, but it was a very big deal. And my boss was really excited about it. No other administrator had been invited to this meeting. I was very lucky. So I went along to this meeting, and it was held on it was a 60-bedded ward in that hospital. I walked into what was the day room, a huge room, and there was laid out a huge table with a white tablecloth. All the charge nurses were sat round it. There was bacon, eggs, sausage, tomatoes, fried bread, the whole works on the table. Everyone was sitting down, tucking in. And I went and sat down and tucked in with the rest of them. And as I started to eat my breakfast, and we started to talk about how we were going to make great innovations like allowing the patients to wear their own underwear, how that perhaps that we might, in circumstances, be able to find a way of giving them their own toothbrushes. When we were looking at all of that, and eating that breakfast, I looked round and I could see all of the patients kind of sat round the outside of this side of this day room, and they were sat there. They didn't have any breakfast, or one or two of them had a bit of toast. The rest of them had nothing at all. And it dawned on me as I sat there what was happening. I was being inducted into a culture. I was being inducted into a culture where it was perfectly reasonable and acceptable for all of the food that was provided for patients to be ate by those charge nurses. And I became more and more horrified as I sat there with this group of they were not bad people in the sense of the way in which some of the abuse happens at the moment. But they sat there. And I thought, what on earth am I going to do? What am I as a junior administrator going to do in these circumstances? And obviously I finished the breakfast. That's terrible. I shouldn't have said that. It's that bloody chimp again. I don't know about that. I finished the breakfast. And of course what I did what lots of people do. I mean, I went to see my boss and I said, look, this is just unbelievable. I just couldn't believe it. He said, yes, David, you'll learn. You'll understand. And what happened to me, I guess, was what happens to lots of people who do that sort of thing. I got moved. I got moved to another hospital. It was described at the time for my own protection. I thought it was an interesting way of describing it. And from that day on, you don't have to tell me about the importance of culture. I saw it with my own eyes. There were other parts of that hospital that were absolutely fantastic. Therapeutic communities that were organised around the individual needs of patients. But that culture was... And of course, you didn't just break that culture by telling them to be better, or to tell them to be more, to treat patients with more dignity or be more compassionate. The way we dealt with that culture is we completely changed the model of care. We completely changed the way in which those patients were treated. We closed those organisations down. We moved people out into the community and provided support there. So whilst you attack culture, while you absolutely have to do culture, you have to think about the model of care and what impact that has on the way that culture is developed. And the second thing about culture that I learned was when I worked in a large district general hospital. For those of you who know about these things, I think it was described as a bog standard DGH in the terms. I worked in a fantastic hospital, great people, and I learned all about teamwork in all of that. A very simple concept and something we would all sign up to. I learned that working in teams, managers, clinicians together, there was almost nothing you couldn't deliver. There was almost nothing you couldn't deliver for patients. And the interesting thing about all of that, I don't know whether any of you, I'm sure you all look at the staff survey and what comes out of the staff survey. What's really interesting if you look at the staff survey is that when asked the question, do you work in a team? There is an enormous difference across organisations, I guess even in this room. Some organisations, 20-30% of the staff say they work in teams. In some organisations, it's 98%. So a very simple thing is go back and have a look at your own organisation. See where you are on that continuum, because it is really, really important to your patients and really, really important to the culture of that organisation that we promote teamwork in an organised and sensible way. But it's not just being part of a team. What you need to do as a team, you need to identify that you have the same objectives. You need to make sure that they are measurable, that they are ambitious, that they make an impact on your patients. And when you look at the figures of the number of people who have ambitious objectives for their team, it's smaller. So working on teamwork is really important for culture. And I'm not just saying that because that is a nice thing to have. That's a bit of organisational development for us all to go away and think about. It's important because it is the biggest connection between the staffing that you have in your organisation and mortality. If you look at the work that's been done, the research that's been done by Michael West from Lancaster and Aston university, and it is compelling research to look at. It shows that the biggest effect on mortality is the nature and way in which your teams work. Even bigger than the numbers of doctors and nurses that you have. So think really carefully about your organisations. I'm doing it in mine. Identify your teams. Make sure that they have stretching objectives that are ambitious and deliver great things for patients. In that way, we'll turn a kind of blanket problem, we have a problem with culture, into specific things that we can all do, both to improve services and improve the culture of our organisations. The second area I want to talk about is planning for the future, sometimes known as strategy. A really important thing, I think, for the NHS. Really important. It's completely connected and interacts with the political nature of the sorts of work that we do. If I think about, I've been in the job now for probably what might be described as 2 political cycles. And it's very interesting to see how that actually operates. And it never operates by Secretary of State saying, don't do this and you can't have any of that or whatever. It just kind of emerges from the political arrangements that we're in. So if you think about that timetable and the way it works. I saw an election for Labour, the Labour won. I then saw an election that the coalition won. And what happens is before the election, it's quite difficult to make change. Let's kind of not think about change. Let's batten down the hatches. Let's make sure we just do what we have to do to get through the next period. In Labour terms, when they won the election after that, it was, right, we've got 2 years now to make some change happen. Let's get on and do it. And we did quite a lot of change, if you look in the NHS, after that particular election. Although I have to say that Patricia Hewitt, in lots of ways, paid the price for all of that change, that she advocated, I think, a very courageous Secretary of State in lots of ways. You then get to the period before the election where, again, it's let's batten down the hatches. The difference last time was, though, that what happened during that general election period, the 2010 general election, is that political parties went around the country making promises of no change to a whole set of local populations. If you remember all of the things around moratoria and we weren't going to have change and all the rest of it, we said at the time it was not the right thing to do. We said it was not the time, but that's what happened. And so what happened when you got a new government in, we wasted those 2 years where you can really make change happen. We spent our time talking about reorganisation and changes and all that. We didn't talk about the really important changes that are required for the NHS. And now we're entering another period. Now, the NHS, in my view, at the moment, stands at a crossroads in relation to all of this. And we cannot allow the tyranny of the electoral cycle to stop us making the real and fundamental changes that we need to make to the NHS. We cannot allow that to happen this time. We will be letting down our patients and our communities if we did. So we need to think about how we're going to create a strategy, a long-term plan that gives sustainability to the NHS. People in this country should beware of political manifestos that say, with a little bit of growth, with a bit of management cost savings, with a bit of improvement in procurement, and a bit of integration, you can solve the long-term problems of the NHS. You can't. We need absolute clarity and honesty from our political leaders about what the impact of living with the financial climate that we're in for the next few years. One of the things I think that's really important in all of this is to think about the way in which we talked about QIP a few years ago. we were looking ahead and we were thinking, well, for the next 3 or 4 years, we're going to have little or no growth. We certainly weren't thinking that in 7 or 8 or 9 or 10 years there'd be no growth. There was an assumption at that time that somehow things would turn around. Well, they haven't, and so we really do need to think all of this through again to make sure that we've got the right plans in place for our patients and our communities. It's really important that we take this opportunity. And that's why when I worked through the plans for change for the NHS as part of the white paper and the work that we did with Secretary of State at the time, there were 2 things about those changes what I thought were really powerful. One of them was the development of clinical commissioning, the idea that clinicians could lead service redesign for our NHS going forward. It seemed to be a really powerful thing that we hadn't had extensively in the NHS in the past, and we could really make a difference with it. And the other one was the establishment of NHS England, at that time identified as the NHS Commissioning Board. An organisation that was capable of looking ahead, of getting us out of the tyranny of that electoral cycle, to think about the NHS over the medium to long term. Now, if you look around the world, different healthcare systems are handling this problem differently. In some parts of the world, they're going for, what we'll do is we'll cut costs. We'll reduce significantly the costs of the inputs. And you can see in some countries where they've gone for 15, 20, 25% reductions in the pay of people who work in the service. In some countries, they've gone for a reduction in the offer. They've said, we can't afford to provide you with a complete offer anymore. You as a patient, you as an individual are going to have to pay more. In this country, because we have the NHS, we've said we're not going to reduce the offer. We're not going to compromise on free at the point of use. We're not going to have more money. So the way we square that circle is to redesign the services that we have. It is absolutely vital. I don't believe, I've worked with many politicians fantastically committed to the NHS, fantastically committed to services for patients, but because of that electoral cycle, they have enormous difficulty being able to think beyond the relatively short term. And it's our job to make that happen. And it seemed to me institutionally, we were creating something that was capable of doing that. And that's why NHS England will be developing with you, with the NHS, with the other organisations, a shared vision, a shared strategy about what the NHS of the future could look like. Not one which is based on the reduction of the offer, but one which is based on changing the way in which we deliver the offer for our patients and our communities. A really important historical role for us all to play in those circumstances. So how are we going to do that? Well, the first thing we need to do is to set out clearly the case for change. We all intuitively understand what the case for change is, but we need to set it out graphically for our patients, for the public, and for politicians. We need to absolutely make it clear what the case for change is, what the impact of technology is, what the impact of rising ambitions of our patients and our clinicians are about making the NHS genuinely a world-class healthcare system. And we are not short of ambition in those areas. But there is a consequence for the way in which services are delivered. And we need to start to spell those consequences out in a very open and public way. We cannot, in a sort of technocratic way, sit in a corner and have clever thoughts about this. We need to both make that case for change, but we then also need then to engage the whole population in what I would describe as a big conversation about all of these really important issues. We need to create the climate. I don't think if we wait for politicians will never run around saying close hospitals, do this, do that. They will never do any of that. It's our job our job as leaders in the NHS to make the arguments with our patients. I was in West Cornwall some months ago, and I went around the hospital there, fantastic hospital there. They wanted to change the way in which their A&E services were delivered there. What they had a 20,000 people marching through the streets of Penzance. The fact that only 15,000 people lived there was an interesting side point. They had an enormous campaign, and I met the clinicians, and there was a couple of clinicians. There was the consultant in A&E and a local GP, who said, we can't go on like this. We cannot live in these circumstances. And what they did, they booked a room in a ballroom, local ballroom. They invited the public, the population, and said, look, these are our issues. These are the things that we're really worried about. We don't believe we're providing a fantastic service to some of these very sick people. We don't think whatever you do in terms of resources that we will ever be able to do that. We want to create a centre that does all these other things for the community. Can you help us do it? And they did. And it is remarkable to go and visit it. They even call it an urgent care centre, ironically. And it has huge community support. But they did it in a completely different way. They did not say, we've had to think about it, we've done a clever analysis, now here is the answer, and can we sell it to you? They didn't do that at all. They posed a whole series of open questions to make it happen, and it worked. And there are many examples of work that are people doing at a local level to make this happen. So we need to make that conversation. So we need to create a big conversation to enable that to happen, and that's what we plan to do. There are then a series of things that only NHS England can do, the kinds of the technical things that we need to do to underpin that case for change, that big conversation, that way forward for the NHS. Specialised commissioning, critical thing for the NHS going forward. In lots of ways, people have described it sometimes as our crown jewels. Some of the services that we have, specialised services, are genuinely world class. There's a danger that we might lose some of those. There's a danger we might lose the staff who work in them. As the rest of the world modernise and centralise and organise, specialise those services, we're in danger of being left behind. I don't know what the final outcome of safe and sustainable paediatric cardiac surgery is going to be. But what I know is it is impossible to modernise a world-class service having to go through the kinds of processes that we've gone through over the last 3 years. 3 years. And still the change hasn't happened. Something that we've probably known for 10 years before that. The system we have at the moment to deliver change rapidly in the interests of patients is simply holding us all back. So we need to think very carefully about what that is, that new system is, and how we can make it work. So specialised commissioning, something that NHS really has to do. Primary care. I talked about primary care early on. I'm a massive fan of primary care, but it doesn't deliver for everybody, for people's needs everywhere, and it needs modernising. It would be extraordinary, wouldn't it, if a model that was identified in 1948 was still suitable everywhere where we are. So we need to have a radical look at the way in which primary care works. I know that many of the CCG leaders want to see a radical change. Indeed, many GPs want to see radical change in general practice. So let's see how we can make that a reality over the next 2 or 3 years. We also need to take on board the kind of changes that will be needed to the incentives in the system. Everything from the tariff through to the quality premium, through the contract, all of those need to be radically altered to support that case for change and the big conversation. And finally, we need to really make the most of transparency and patient power. And I'll come on to that in a while, patient power being my final point. So those things we are committed to do. We're absolutely determined to do. In fact, it was the reason we were set up. I find it extraordinary that people will argue that actually you don't need a strategy. You don't need to understand where you're going to. In an environment where if you're critical, you could say we've fragmented the service. In other ways, you could say we've localized it. Whatever way you want to look at it. There are lots and lots of organizations, lots and lots of competing resource requirements, lots and lots of different professions. If you can't get alignment about the direction you are going in, I think that's a recipe for managed decline for the NHS over the next few years. So those people who say you don't need a strategy, you don't need to do this work, I think their alternative is managed decline. And I certainly in the next few months do not want to be part of that in any shape or form. And indeed, I think when I talk about this strategic approach, I'm not talking about a document. There's not going to have a great big tome that says this is the strategy of NHS. This is a process I'm talking about of engaging with our patients to make services better and improve outcomes. That's what I'm talking about. And each of those things I've talked about, well, there'll be products, there'll be documents, absolutely. But out of that will come a process, a movement for the NHS to make it happen. So my final point then is about patients and about patient power. A number of people will stand up in front of you, I know, and they'll say the single most important thing about the Francis report was, and you could put in a whole set of things. I'm going to do it now. In lots of ways, I've for all sorts of reasons, as you can imagine, have been absolutely engaged in this for the last 4 or 5 years or so. And the most important thing that comes out of Francis for me, and I think for us all, is listening to patients and then doing something about it. It's as simple as that. When you scrape away all of those volumes and all those millions of words that have been written about it and all of those headlines and all the rest of it, it's listening to patients and doing something about it. It's something that we're all committed to, but it's something that we all need to constantly engage our people in our organisations around. It's easy to say, but consistently it's very difficult to do. But not just listening to those patients who make a noise, listening to all of our patients, those who have, for a whole variety of reasons, difficulty in connecting with us. In NHS England, a few months ago, we decided to have a joint board meeting with a group of people with learning disabilities and their carers and their advocates. A phenomenal meeting. Many people, I'm sure, in their own boards will have done something similar. It does genuinely shift the way in which you think about the world. We had a fantastic day, a challenging day, but a genuinely enjoyable day with these people with learning disabilities. And they told us a story. They told it in pictures. They told it about a woman who was in her 30s, a woman with learning disabilities. She'd lived with her parents, her mother and father, all of her life, and she had a condition which meant that she needed a minor operation. So she was admitted to the local hospital. The mother went in with her and said, look, she's never slept on her own. She's always slept in our bedroom with her mother and her father. So was it possible for at least her mother and possibly her father to sleep in the same room as her during that night, that one night she was there? And the hospital said no, that wasn't what they did. In the children's unit they did it, but in adults, no, we don't. We don't do that. She got very upset, the mother did. She went through the process right up, I understand, to the chief nurse to say, can you arrange this for me to sleep in this room with my daughter? Everyone said no. It's not the way we do it here. What happened that night, they went home, they left her there. What happened that night is she completely wrecked the room. They showed us the picture of the room that's completely wrecked. She smashed everything in that room that you could see. Everything in that room. And she attacked 2 of the members of staff. It got so bad that night, they had to section her that night. And then the next picture they showed us was her being abused by somebody on a panorama show about Winterbourne view. A completely graphic explanation of the importance of listening to our patients. Something very easy to say, but we have a responsibility to create the environment that our staff feel empowered to do that. It's so important for our patients. And the second thing I'd say about patients is that they need to be part of the solution. Patients not only need to be able to talk to us in our big conversation about the way in which services operate, they also need to be able to take control of their own health and healthcare. Some of you may know, on Christmas Eve, I was diagnosed with diabetes. Some of you may know that because Tim Kelsey tweeted it. But I got diagnosed with diabetes. It's an extraordinary experience to turn in those circumstances. I went to see my GP. They did all the stuff. They said, yes, you've got diabetes. It's quite a difficult thing, I think, particularly for someone, a healthcare professional, someone who's worked in the NHS, to kind of reflect on that and say, all right, I've got an illness now or a condition which could involve with me losing my limbs, my kidneys packing in, having a heart attack, and probably dying of a stroke. Not only that, it's your own fault. That's quite a difficult thing to swallow, but I swallowed it. And what I was determined to do right from there was to take control myself of my own health and healthcare. And I don't know, I don't want to bore you to death with my ill health, but one of the things they gave me was a monitoring machine. So I take my blood glucose levels 4 times a day, and I have a little chart that I put them on. Now, I'm not a stereotype here, but give me a chart and a target and a trajectory, and I'm absolutely with you. They could have absolutely designed that interaction for me. And I've been absolutely at it since then. I've done everything that I need to do. I've bored everyone to death who I work with and my family. I've started the course, and I can't remember whether it's Daphne or Desmond, but it's a fantastic thing if you think about it. When you're diagnosed with diabetes, you get to go on a course paid for free by the NHS. Well, it's not completely free because it costs £4.50 to park my car. But the thing about that, they said you could claim it back, but I felt slightly embarrassed about doing that. It was Kidderminster Hospital for those of you who watch it, and they need every penny they can get. So. I went on the first course, and it's fantastic. I was by far, and no, to be fair, the only person who knew who I was this poor, hapless nurse specialist who had to do the teaching on it. I do feel for her, but she's fantastic. She is fantastic. Nobody else then. I was in a room with 20 other people. I was by far the youngest person there. Most of them were in their 80s and 90s. Interestingly, for me, was that when they were asked who had access to the internet, every single one of them had, challenging a lot of sometimes preconditions about all of that. We had one of those. You'll all know this very well. We had at the beginning of the session what they call an icebreaker. I kind of, oh God. I thought, and me and two of the ladies who were in their 80s sat down and we talked to each other about why we were there and all of that, and we did all that. And it was very interesting because they asked me about they didn't ask me what I did for a living because nobody's interested in that. But they said, and I don't think there's anybody in Kidderminster who reads the Daily Mail, by the way, just in case you're worried. And one of them said to me, so what happened to you? And I said, well, I made the judgment that I wanted to control this myself. And when the GP said to me, you can have these tablets that will reduce your blood glucose level, I said, look, I don't want. I'd rather try with diet and exercise. I'd rather do it myself. And he was not convinced I would be able to do it, and neither was I, to be honest, when I said it. But he said that, so I tried it. And this woman said to me, she said, can you do that? I said, what? I said, can you say no to the doctor? Can you tell him? I said, of course you can. And this other woman said, no, surely not. I said, yes, no, you can. You can say to a doctor, I don't want these things. So anyway, I was pretty convincing in all of that. When we got into the plenary session, of course, what happened is, first hand went up the one side of me. He says, is it true? And the nurse said, of course it's true. You can control your own healthcare. And in a very simple and kind of small level, you can see there how people taking control of their own healthcare makes such a difference. In fact, the future of the NHS depends on people in rooms like that taking control of their own conditions, making sure that they are absolutely on top of what they're trying to do. Really important. But that's not the only thing about patient power. That's not the only thing we need to do. If you think about the way in which most industries have modernised themselves over the last few years, if you look at banking or retail or whatever, they've all involved customers doing more, taking more responsibility, and actually doing more. And if you think about the challenges in front of us, and you say to our patients, look, the alternatives are you're going to get less service, you're going to have to pay more yourself through your taxes or individually, or you've got to take control, and you can do more for yourself. I think most people will go for that. What we haven't done, though, is taken that seriously enough. Other industries have invested huge amounts of money into that to make it happen. The issue for us, though, is we haven't created the business case. We haven't, in a sense, done the financial calculations. What would it mean if our patients took more control and more power? What would it mean if those people in that group controlled their own health and healthcare? What would it mean if patients took more responsibility for their own records, for their own administration? They are booking more themselves, organising what they did more. I think we would find that is a significant resource. And that's one of the things that we need to do as we go forward. What it will do, in a sense, to do the financial calculation, to show the contribution that our patients can make directly to the improvements in the NHS and what financial consequences that would be for us. I think that completely changes the nature of that big conversation I talked about earlier. It's not then a conversation about what we as health professionals can do for you, but what we can do for each other. I think that would literally transform the relationship between the NHS and the patients and communities that we serve. And so we all need to go away and start to think about that calculation. It will certainly produce a whole set of discussions. It will also produce an enormous amount of focus on what the investment we need to make it happen in reality. So very finally, those three things: promoting a culture, working on teamwork, getting our plan for the future, our case for change, every CCG having a 5-year plan for how they're going to transform services in their locality, engaging patients, listening to them, working with them, engaging them in the solution to those problems. They're the things we should go out of this room, go out from this conference and do. And I'm going to focus my attention on those things as we go forward. Over the last 7 or 8 years, I've worked with 3 Prime Ministers, 5 Secretaries of States. I've seen 303 PCTs. I've seen 151 PCTs. I've seen 28 SHAs. I've seen 10 SHAs. I've seen a myriad of development of foundations. I've seen all of those organisational changes during that period. And the thing I've learnt more than anything else is that where we go wrong is when we lose our sense of purpose, when we get confused and organised around things that really are not as important as that basic purpose is. And the thing I've always tried to do, it was the reason that I worked so hard to develop the NHS Constitution those years ago. And that sense of purpose for me is best summed up in a part of the Constitution that I just want to finally leave you with. The NHS belongs to the people. It is there to improve our health and well-being, supporting us to keep mentally and physically well, to get better when we're ill, when we cannot recover, to stay as well as we can to the end of our lives. It works at the limits of science, bringing the highest levels of human knowledge and skill to save lives and improve health. It touches our lives at times of basic human need, when care and compassion are what matters most. We need to have that in the front of our minds every day. Thank you.
There's no time for questions. Sorry.
That's it.
Unless you want to say something. Well, ladies and gentlemen, he's done something else you're going to approve of. I don't know if you'll approve of this, but he's left no time for questions. So, rather cleverly. Actually, I'm just going to ask one thing.
Yes, go on.
Who should replace you?
I have to say, the last few months have been very difficult in the job, undoubtedly. And some people might be put off because there is a level of scrutiny about your private life, about the things that you do that I've never seen before. And I don't want that to put people off. So those of you who've got scurrilous private lives, feel free to apply for the job, and you know who you are. But it is a fantastic job. It is just the most wonderful job. I've done things and met people and been in circumstances that I would never in a million years have come to. You see all sorts of things that people don't normally see. You have debates and discussions with politicians, and you see the NHS. You have, in a sense, the licence to go anywhere in the NHS and talk to frontline people about what they're doing and the great things they're doing for patients, and you get to see patients, and you get to make things happen. It is a fantastic job. And I think who gets it? One of the great things about this, of course, is I don't have to have any responsibility at all to decide who replaces me. All I can say, it is just the most wonderful job, and it's an absolute privilege working with the people in this room.
Sir David Nicholson.